Okay, sounds good. Okay, hi everybody. My name is Martin King. I'm here with Dr. Ronald Chen. We're here to go through some challenging cases for genitourinary malignancies. So it's nice to meet all of you. If you have any questions, please feel free to reach out. And we'll also have a question period after each case, but we just want to try to make this as interactive as possible. So I'm going to start talking about the first case. Hold on. Okay. The first case is a patient with radiorecurrent prostate cancer. Before, we never saw these patients that often, but we see them more and more now because of the utilization of PSMA PET for patients with biochemical recurrences. So this is a patient. He was 84 years old. He was diagnosed initially with prostate cancer, unfavorable intermediate risk, Gleason 4+3 with 11 out of 12 cores, and he had standard of care treatment. So 6 months of hormonal therapy, as well as external beam radiation, dose escalated 79.2 gray. He had a good PSA response on treatment. So for 8 years, his PSAs went to undetectable. But from 2 years prior to presentation, his PSA started to increase. And it went up from nearly undetectable to about 3. And his PSA doubling time was about 13.4 months. So between 1 to 2 years. So it's actually a pretty recognizable rise. He had good urinary function, so he had an IPSs of 3, but he was on 2 tablets of Flomax, so he has some compromised urinary reserve. And he had a PSMA PET scan that showed that there was focal uptake in the left posterior lateral gland. So I'm just trying to advance this. Sorry, I'm trying to advance the slides. Is it advancing? Is it? Press this? Oh, now I can. Okay, good. So for all of these patients that we see, I typically like to get a biopsy. And the reason for the biopsy is to understand where the cancer is in the prostate and where the cancer really isn't. And so this patient had a systemic plus targeted biopsy, and the results show that there was 4+4 disease in the right mid gland. He also had an MRI that showed a 0.8 centimeter lesion in the left peripheral zone, and this was a focal lesion. There was some slight diffusion restricted, but as with many of these cases, the MRI is just much more difficult to interpret because of prior radiation fibrosis. And so, one of the questions is, among patients with biochemical recurrence after radiation therapy, how many of these patients actually have localized disease within the prostate on PSMA PET? There was an early study. It was a prospective study in 2019. It was done in Vancouver. And it looked at patients who had biochemical recurrences after prostatectomy and biochemical recurrences after radiation. Oops. And what it tended to show was that the rate of disease within the prostate bed after surgery was 14%, but it was more like 63% for patients who had biochemical recurrence after radiation therapy. So it's actually pretty high, over half of these patients. And in another study of patients who had brachytherapy, local recurrences were up to 62.9% as a component of the recurrence. There was also regional recurrences and distal recurrences, but local recurrence was about 63%. In terms of how do we treat these patients, or should we treat these patients? And it's actually a good question. Many of these patients don't actually die from prostate cancer. And so observation for patients is actually quite a reasonable option. Other patients can go on intermittent hormonal therapy. And then another option that has probably been gaining in prominence is local salvage treatments. There was a recent analysis, meta-analysis, that looked at salvage treatments after prior radiation therapy. They looked at radical prostatectomy, cryotherapy, HIFU, SBRT, HDR, and LDR brachytherapy. And what they showed was that compared with radical prostatectomy, which had an increased risk of severe GU toxicity of 21%, the rate of severe GU toxicity for radiation, whether it was SBRT, HDR, or LDR, was only about 5 to 10%. On the other hand, the 5-year relapse-free survivals amongst all the modalities in this meta-analysis was quite heterogeneous, was about 50 to 60%. So this is why we've often favored salvage reirradiation for patients who have radiorecurrent prostate cancer. So what is the evidence for repeat treatment for these patients? There was one cooperative group study, RTOG, I think it was 0526, which looked at 100 patients who underwent salvage LDR brachytherapy. The primary endpoint was the percentage of patients who had grade 3 toxicities at 9 to 24 months. And the result was that 12 patients, or 14% of patients, had a grade 3 or higher toxicity within this period. The majority of the patients had GU toxicity. As a result, whole gland salvage treatment does have some patients who will have difficult urinary function afterwards. In a follow-up publication, they showed that the long-term biochemical failure rate was about 46%. What is another type of treatment? One treatment that has been gaining prominence is focal SBRT. This was a series that was published just last year. It was 38 patients who were treated with 6 months of hormonal therapy in 35 gray and 5 fraction to MR-defined target volume. So this target volume was CTV. CTV was the GTV noted on MRI, plus any areas that were biopsy positive. And there was a PTV margin of 5 millimeters. In this study, they reported a 5-year event-free survival of 58%. They also reported a peak acute and late RTOG toxicity. And what they were able to show was that probably the rate of late GU toxicity was about 16% on this study. But they try to emphasize that only 2 patients had durable grade 3 toxicity. And so this suggests that another potential treatment option would be focal SBRT. And so, one of the questions is, who are the ideal candidates for repeat radiation? What I think is ideal are patients who have local-only disease on PSMA PET, so no regional or distant disease. Patients who had no grade 3 GI or GU toxicity after primary radiation therapy. Such patients probably have more radiosensitive biology. A current IPSS score less than or equal to 15, a PSA less than 10, a PSA doubling time greater than 6 months. Many series report that a PSA doubling time of about 3 months, the chance of biochemical control after 5 years is probably 0%, because these patients often have micrometastatic disease. Another thing that I really advocate for is biopsy-proven intraprostatic disease in order to better understand or obtain pathologic proof that what you're seeing on your PSMA PET scan is real. One of the potential reasons is that some patients may have a positive PSMA PET scan that might result in that might actually be a PSA bounce if obtained too soon after radiation therapy. I do recommend or consider focal treatment if the findings on the PSMA PET scan, the MRI scan, and the biopsy are fully concordant. If systemic disease does not show disease outside of the PSMA, PET, or MRI-defined lesions. And the reason for this is that focal treatment may reduce toxicity. And I believe that probably the rate of grade 3 toxicity from focal treatment may be more like 5 to 10%. There's different ways of treatment. There's true focal therapy, quadrant or hemigland, or subtotal ablation. What I recommend is that when you do focal treatment, you're pretty generous because there still might be microscopic cells that are not seen on the PSMA PET scan or the MRI scan. I do feel that we want to try to minimize missing disease as much as possible. So for this patient, he was older, he was 84. We actually did focal LDR brachytherapy. Single procedure, unique radiobiology, allows for pronounced dose escalation to the lesion. What we essentially did was we did MR ultrasound fusion of the GTV onto the ultrasound image, drew a pretty generous 8mm margin. So a lot of the focal HIFU series for radiation, for HIFU was about, 6 to 7 millimeters. And so we just use 8mm. Prescription dose is 145 gray. We put in 26 seeds. I did not use a rectal spacer for this, although it could be considered. This was kind of we got our day 30 scan and we were able to put quite a bit of dose into the tumor. It was about 191 gray. And at least at 3 months later, his PSA did drop quite a bit. And his GI and GU symptoms were back to baseline. So in conclusion, prostate reirradiation, it is an increasingly viable treatment option for radio-recurrent prostate cancer. It may be curative in some, and it may delay the need of ADT in others. Focal treatments may reduce the risk of reirradiation for patients with low volume intraprostatic disease. However, accurate targeting and generous margins are critical. So I just wanted to stop here and see if anyone had any questions about treating radio-recurrent prostate cancer or any experiences. Hi.
I would like to know the initial performance status of this patient.
Yeah, so a lot of these patients, most of the ones that I treat, performance status is probably 0 or 1 ECOG. So they actually have pretty good performance status. When they're like 2 or 3, usually I just say maybe observation or intermittent ADT may be better for them. Yeah.
Would you consider re-implant the spacer if you do in the re-SBRT? Any experience?
Yeah, so we can definitely consider spacer for these patients. We did have an old series that was published where there was kind of where a patient lost his rectum because there was a lot of fibrosis, and so we try to be as careful as possible with it. I tend not to really do that much spacers just because the risk of GI toxicity has been quite low, in RTO G0526 for that SBRT series. But I think it certainly could be considered for some patients who are extremely thin. It's a lot of it is just, make sure you don't hit the rectum. And if you have to put a lot of pressure to develop that space, just abort. And so you just have to be really careful when you do it. Yeah. Any other questions?
So Martin, I like LDR brachy for salvage re-radiation also. Do you use a different C strength for re-radiation? What C strength do you use?
So we use pretty much the same one that we do for monotherapy. For a lot of these focal treatments, though, you can get a pretty high dose, like you can like 200 gray or higher. But I haven't really been adjusting the seed strength.
I use a little bit weaker seeds. Just
okay.
The dose throw off is not as far as.
Right.
I think it's different style for different people.
Yeah. No, that's a good point. Yeah, it's something I should consider. Any other questions? Okay. So I'll go on to the second case. So the second case, it's a very interesting case. So this is a 90-year-old woman who had a prior right kidney angiomyolipoma. So she had a right simple nephrectomy in 2000. And, while she was undergoing surveillance for a pancreatic cyst, they noted that the left kidney lesion was actually growing in size. And so, before it was about 3 centimeters, but, when it was about 3 months before treatment, it was more like 4.2 centimeters. And the characteristics were that of renal cell carcinoma. And so she actually had a lot of cystic disease. So this is her kidney. You do see a big cyst here, but the area of concern is in red. And so this is kind of the area of the RCC tumor, and it was actually right up against the stomach. And so the question is she a candidate for treatment to that RCC? So she's not a very good candidate for surgery. She's 90. She also has some, decreased renal reserve because she had her right kidney removed. And she does have, her GFR was about, wasn't, I don't think it was above 60. I think it was more like 40 or 50. And so what's the evidence for treatment for renal cell carcinoma? Fortunately, we have a very recent study, the FastTrack-2 study. This was a study that was performed, multi-institutional study that took 70 patients. They had biopsy-proven RCC, a single lesion, and they treated them with radiation therapy. All of the patients who had a GFR less than 30 were excluded. And then patients who had, prior high-dose radiotherapy or a very, very large tumor or direct bowel contact were also excluded. Patients were treated with either 26 gray times 1 fraction for a less than 4 centimeter tumor, or 42 gray in 3 fractions for a 4 to 10 centimeter tumor. And the primary endpoint was local control as defined per RECIST 1.1. And so it's really just kind of measuring whether patients had stable size, decreased size, versus an increase in size. And then patients were followed based on CT scans, GFRs, renal function scans, and then whole body scans if progression. What they found from this study was that at a median follow-up of 43 months, the 12-year, the local control at 12 months was 100%. And when they, drew the line out to 60 months, there was actually no local failures or local progressions. There was grade 3 AEs in 7 patients, 10%, including nausea, vomiting, abdominal or flank pain, colon obstruction, or diarrhea. But for the most part, patients did really good. They also looked at the 2-year GFR decline. And there was a GFR decline about 14.6. Patients who had, contralateral kidney actually had very minimal decline, but patients who had just like ipsilateral kidney had more pronounced decline. And so, the question was, how do we treat these patients? And what we were doing at this time was we were actually treating them with our MR-Linac. So this is online adaptive treatment, which allows for real-time tracking. Real-time tracking means we can actually follow the patient's tumor as they're undergoing treatment with MRI. We also had adaptive planning, and so we were able to recontour the kidneys and organs every day in case that things have changed, and it allowed for improved visualization. And we, some other Dr. Lehman and his team, they did publish their experience, MR-Linac online adaptive radiotherapy, SBRT, and in this trial of 20 patients who were treated with 40 gray and 5 fractions of radiation therapy, there was only 1 local failure at 30 months. This patient actually had more advanced disease with an IVC thrombus. And from a dosimetric standpoint, about 2/3 of patients actually benefited from adaptive treatment. They looked and saw that there was a decrease in tumor size of about 0.2 centimeters. And so, it's not, a large regression, but it was actually kind of stable. There was also a very minimal decline in the eGFR of just about, 2 milliliters. And so this was actually more favorable compared with FastTrack-2, in which there was kind of a 15 milliliter decline. There was 1 grade 2 toxicity, no grade 3 toxicity. And so this is just some images of the patient. Their tumors here, and then this is the stomach. You can see it on the CT planning scan, the MRI planning scan, and these are some adjacent structures that were included, including the hilum, the left kidney, and the bowel. In terms of this treatment, there was a 3 millimeter margin that was placed around the GTV. The PTV V40 was greater than 95%. GI organs all had the same constraints, V35 less than 0.03 cc's, the left kidney V10 less than 25%, the hilum V23 less than 67%. So everything really met metrics based on these DVH curves. It is a little bit hard to see with all the different curves. And so, in terms of follow-up, what they found was that this patient's tumor actually increased in size at about a year out. But then it started decreasing in size, and so this was a little bit of pseudo-progression. In terms of the kidney function, there was really no real change. So it didn't really get that much worse after treatment. And so this was considered a success for a patient who was 90 years old that was completely non-invasive. In conclusion, kidney SBRT is an effective and safe option for non-surgical candidates, can be used for larger tumors as well as centrally located tumors. And it does, MR-Linac may improve precision and may result in improved outcomes when delivering SBRT. I think there certainly could be a role for online adaptive for at least some of these patients. I just want to stop here and see if there was any questions or concerns. Yeah.
I have a question about the previous case about the side effect. You mentioned about the bowel obstruction and the other side effect. Is the problem?
You mean the bowel obstruction for the kidney SBRT?
I mean the side effect after radiotherapy. You
Yeah.
list how to manage the side effect.
Yeah. So in terms of the side effect, there could certainly be some side effects to this. I think a lot of these are kind of more self-limited, it's a lot of it would be if they have nausea, putting them on like Zofran, just making sure that their stools are regular after treatment. Referral to GI if needed. But I think that they're typically pretty temporary and they do go away. But there is a risk of side effects with this, especially because of the bowel.
Previous slide, you mentioned about
Oh, wait.
here.
Oh, here. Yeah.
The colon obstruction.
Yeah. So the colon obstruction probably it might have been too much dose to the adjacent bowel that might have, and for those cases they probably needed to go to surgery to be able to have the, to be able to repair or remove that tissue and then repair it. Yeah, if it's. Yeah.
Is it common to see the pseudoprogression in this kind of patients?
Yeah, so I think it could be, and there's, that's one of the things that is, some people are a little bit concerned with, how do you interpret control for patients who are treated with SBRT, and I think it is a relatively common phenomenon that you don't just label it progression, but you kind of follow things out until, until you can see if that tumor size does decline. Probably just following it out by RECIST, you would be able to tell if the progression was significant enough where you'd have to go back and think there is progression. But I do think that it is a phenomenon for kidney SBRT. Yeah, just follow up by CT.
Oh, no MRI or other?
Yeah, you can follow up by CT or MRI. And this, in these patients here, we followed by MRI. Yeah, and the ones that we treated, I think in the fast track study, they followed by CT if there was progression. Yeah.
Hi, I'm Dr. Shen from the Chongqing Memorial Hospital. And one small question also regarding the toxicity of the kidney saver. I'm curious about that. Did you experience any kind of urinary tract obstruction after a kidney saver? Because Dr. Tsai in last section mentioned that she experienced the urinary tract obstruction in a kidney saver. So I'm just wondering that if you have any that kind of experience. Thank you.
Yeah, so in the study that that was published, we didn't really experience that urinary tract obstruction, but I think that what we tried to do, at least in this, for this patient, is to put some metrics on the hilum of the kidney to try to reduce the chance that there is any type of obstruction that could develop afterwards. But, certainly I think it is a potential concern. And following with the renal function scans, it's something that you definitely should watch out for, especially if the GFRs do start going down, to really image it and see if there is some type of like a urodynamic or a urogram to see if there's any obstruction that's there.
Thank you. And I have another question. If you meet the situation, the RCC is very large and abutting to more larger amount of intestine, small bowel, would you still use the SABRE regimen to meet the constraint, or you will choose like a more moderate hyperfractionated regimen? Yeah,
I do think that, when it's too close to the bowel and you can't meet that bowel constraint, the right thing to do would be, as you mentioned, to consider alternative treatments, whether that's surgery or kind of a more, kind of a more moderately hypofractionated regimen as you need it. But just to make sure you don't exceed that bowel constraint. I do think that that's an important caveat.
Moderate hyperfractionation doesn't work though, so you can also just do SBRT and chi.
And then chi, yeah, and that's correct, yeah. Thanks. Any other questions? Okay, so, one more.
I want to ask about the detail. Do you arrange patient for a bowel preparation before radiotherapy, such as a decrease the gas or the stool?
Yeah.
Something.
Yeah, no, I think that's a good question. I mean, you definitely don't want the patients to have like a really bloated stomach or anything of that sort. I think that in our experience, I'm not really sure if we put them on like a specific bowel regimen for this. But I think it's something to consider. Like if you do see a lot of gas or something like that, maybe put that patient on it and then just repeat the simulation. Yeah. I don't know if you've had any experience with that.
I don't do any instruction.
Okay, so we have Dr. Chen will talk about bladder cancer. So this works now. So.
Excellent. You warmed it up. Hey everybody. So I have a bladder cancer case. This is an 84-year-old man with a lot of comorbidities: chronic kidney disease, heart problem, DVT, pulmonary embolism, it's not anticoagulation, and of course presents with hematuria. It's a bladder cancer case. Also is Foley dependent, so has a catheter, probably because his prostate is enlarged. And you can see on the CT scan with contrast that there's some bladder tumor there. So initial workup with the CT scan shows a 6.5 centimeter bladder mass. There is right hydronephrosis, and many of you know that hydronephrosis may be a relative contraindication to bladder preservation. And so the urologist saw him and had a TURBT. The tumor was completely resected. Pathology shows high-grade urothelial carcinoma, muscle invasive, and has staging scans to show no metastatic disease. So this patient, even though has right hydronephrosis, which is not great, is clearly not a candidate for cystectomy. So cannot have surgery to remove the bladder because the patient has too many comorbidities, and so ends up seeing me for consultation. So an overall treatment approach for muscle-invasive bladder cancer, the way I think about it is if a patient is a candidate for radical cystectomy, then I am more selective. So other patients who are young and healthy and could have surgery, then I think there are several relative contraindications I would look for. So for bladder preservation. So incomplete TURBT, the tumor couldn't be resected completely by the urologist. If there's hydronephrosis, patient cannot have concurrent chemotherapy. If it's very large, more than 6 centimeters, if it's T3, T4 disease, multifocal carcinoma in situ, or poor baseline bladder function where the bladder is not preserving. So the patient has surgery as an option, then I'm much more selective in who I offer bladder preservation to, and they have to pass all of these criteria to be offered bladder preservation if they have a surgery option. But this patient, of course, has hydronephrosis, which makes them not ideal for bladder preservation. But on the other hand, this patient is not a candidate for radical cystectomy, so he has no surgery option, and radiation is the only option for him. So if he has no other option, then I will offer him radiation, because even if it's not ideal, radiation can still potentially cure him and should be offered to all patients who cannot have surgery. So even though this patient has hydronephrosis, he's not a surgical candidate because he's old and has comorbidities, and I offered him bladder preservation as a potentially curative treatment. So there's a couple of points I want to make. One is that when we are doing bladder preservation with curative intent, when we're trying to cure the patient, having concurrent chemotherapy with radiation is very important. There have now been 2 randomized trials with concurrent chemotherapy. One was from NCI Canada. It's a small randomized trial, 99 patients, and they randomized patients to either radiation alone or radiation with concurrent cisplatin. And in their primary endpoint of pelvic relapse-free survival, concurrent chemotherapy was better than radiation alone. There's another randomized trial, BC2001, where they compared radiation alone versus radiation plus 5-FU mitomycin. And in the primary outcome of local regional recurrence-free survival, concurrent chemoradiation was better than radiation alone. So 2 randomized trials have shown that concurrent chemotherapy is very important when we're trying to cure patients with bladder preservation, either with cisplatin or 5-FU mitomycin. It is true that both of these randomized trials showed a relapse-free survival benefit, but these 2 trials did not show an overall survival benefit, or at least not statistically significant. So in the NCI Canada trial with cisplatin, the 3-year overall survival was 47% with chemoradiation and 33% for radiation alone. Now, this is a 14% survival difference, but it was not statistically significant because I think it's underpowered. It's too small of a trial. Even, I think 14% overall survival difference is a huge difference. If there was a larger trial, I think that would have been, but regardless, this is not statistically significant with a 14% difference. In the BC2001 trial, actually the 5-year overall survival is very similar. Chemoradiation, 5-year overall survival was 49%, and radiation alone was 37%, a 12% survival difference, but still not statistically significant. I think it was underpowered. But in any case, these 2 trials did not show an overall survival difference statistically, but they did show that concurrent chemotherapy is important for relapse-free survival. So I do think there's 2 positive trials showing concurrent chemotherapy is important for these patients. There are multiple concurrent chemotherapy options. Many of the RTOG trials use some form of cisplatin or cisplatin 5-FU. That's probably the classic concurrent chemotherapy we use. The BC2001 trial that I just showed used 5-FU mitomycin, which I think is also an option. And then more recently, there was a trial that showed that low-dose gemcitabine is also an option for bladder preservation. The point that I want to make is that almost every patient should be able to tolerate some sort of chemotherapy. Cisplatin is probably the hardest to tolerate, so usually younger patients get cisplatin. But even older patients with comorbidities should be able to tolerate low-dose gemcitabine. So very, very few patients, if any, should get radiation alone. Every patient should be able to get some sort of chemotherapy for bladder preservation. So low-dose gemcitabine was demonstrated to be effective in the RTOG 0712 randomized trial. This is a randomized phase 2 trial because it's pretty small. And these are patients with muscle-invasive bladder cancer getting concurrent chemoradiation. And they're randomized patients to radiation plus cisplatin 5-FU versus radiation plus low-dose gemcitabine. And they reported 7-year outcomes. And if you look at the outcomes of, so if cisplatin is standard of care, this is all pretty much just as good, if not better, than cisplatin. So freedom from distant metastasis at 7 years, 65, 73 is actually a little bit higher than 65. Bladder intact, metastasis-free survival, 58-68. Overall survival, 48-59. So this relatively small randomized trial actually showed that low-dose gemcitabine probably just as good as cisplatin and maybe a little bit better. And this is much better tolerated for older patients. And many older patients that I have, we give low-dose gemcitabine because cisplatin is hard to take. So for this patient who is 84 years old with chronic kidney disease, cardiomyopathy, lots of comorbidities, he's on anticoagulation. He's not a surgical candidate. So I treated him with bladder preservation, concurrent chemoradiation. I used mini pelvis and the whole bladder for my initial course to 45 gray. And then my boost is to the whole bladder. Some people do partial bladder boost. I always do whole bladder boost to 59.4. And 59.4 is a little bit low, and I'll show you why it's a little bit low. I often try to give it to the 64, 66. For this patient, I couldn't, and I'll show you why. Again, I said I think almost every patient should be able to get chemotherapy, and he got low-dose gemcitabine. 84 years old, a lot of comorbidities, got low-dose gemcitabine. IMRT VMAT, cone beam CT daily to make sure the bladder's in the field, and bladder empty for daily treatment is what we did. And you can see that he still has a Foley catheter during treatment. The reason I couldn't give 60-some gray is because this is an upper slice. There's bowel right next to the bladder. And I don't feel comfortable giving bowel 65 gray when it's so close to the bladder. So I gave 59.4. It's a little bit of a compromise, but I didn't want to hurt him, who is old and has a lot of other medical conditions. So the patient tolerated chemoradiation very well with no treatment break, and he finished November 22. Most recent follow-up this month, he's now 87 years old. Cystoscopy, no tumor. CT scan, no tumor. Excellent bladder function. He no longer needs a Foley catheter. His prostate shrunk after radiation, and so he is now able to urinate without a catheter. He's very, very happy with his bladder function, and he has no disease almost 3 years after treatment, age 87. So I think it's important to sort of show this paper. This is a paper that was published about 1.5 years ago that compared cystectomy to chemoradiation. This was a large series of 700 patients across 3 institutions. This is not a randomized trial, it's a retrospective study. There's no randomized trial, but retrospective comparison of surgery versus radiation for bladder cancer. Now, these patients were included who are eligible for, they're surgical candidates, so they're young and healthy. They're also eligible for radiation, and so they're pretty selective on who was included in the analysis. No bigger than 7 centimeters, no hydronephrosis or only one side hydronephrosis, no extensive carcinoma in situ. So these are pretty good radiation candidates, and so good candidates for radiation, good candidates for surgery. And they use propensity score to match patients between surgery and radiation to compare the outcomes to see whether surgery is better than radiation for these patients. And so they looked at 5-year outcomes comparing cystectomy to trimodality therapy, looking at disease-free survival, almost the same, metastasis-free survival, almost the same, cancer-specific survival, pretty much the same, but radiation actually had better overall survival than cystectomy. There's no randomized trial, but this is actually a very good retrospective comparison of patients who are eligible for both, published in Lancet Oncology, that shows that traumatology therapy is no worse than surgery and possibly a little bit better. This was actually a statistically significant difference showing radiation has better survival. So my overall conclusion for bladder preservation, I think trimodality bladder preservation therapy for muscle-invasive bladder cancer is very effective and similar to surgery. So for patients who have bladder cancer, they don't have to lose their bladder. Surgery is not the only option, and many patients can keep their bladder and have a good curative outcome. They don't have to lose their bladder. And certainly for older patients, trimodality therapy is safer than cystectomy and should be preferred option. Concurrent chemoradiation is better than radiation alone, and almost all patients should be offered some sort of chemotherapy for bladder preservation. And patients with MIBC should be offered curative therapy. If they're not surgical candidates, they should be offered radiation. No treatment is not ideal for patients with bladder cancer. I will stop there and see if anyone has any questions.
Thank you, Professor Chen. Would you please elaborate more about why you always do the whole bladder boost?
Actually, I think in the US, so many of the older RTOG trials that study bladder preservation did partial bladder boost. That's because many of those patients on RTOG trials were treated at Mass General. And at Mass General Hospital, there's a close relationship between the urologist and the radiation oncologist. And when the urologist does their TURBT, they actually draw on a piece of paper exactly where the tumor is. They actually draw a map. And then you have that detailed information. So then when you plan the radiation, you know exactly where to boost for partial bladder. Many of us, not in Mass General, don't have that relationship. So the urologist would do a TURBT. I don't know exactly where the tumor is. And so actually, it's very common in the US to do a whole bladder boost. And so I have always done a whole bladder boost because I don't know where the tumor is. If I do a partial bladder boost, I may miss. And whole bladder boost has been shown to be very safe and effective. There's not increased toxicity. So for most patients, I do a whole bladder boost. If there's bowel that's close by, I may try to cheat a little bit. The whole bladder is my default because I don't know exactly what the tumor is.
And another question is about the presence of the CIS
Yeah.
in situ. From literature, we know that it's a contraindication, but from our own experience, it seems like we could do the bladder preservation followed by the BCG installations. And how about your opinion?
I think that's a very good point, actually. I think, and also I think how much CIS is extensive CIS, like where the cutoff is for extensive versus non-extensive. To me, there's not a consistent uniform definition for CIS. I do think that for patients who have CIS, I do think that offering bladder preservation is reasonable. My philosophy is patients don't have to lose their bladder. And if you try bladder preservation, and if they have a local recurrence, you can do cystectomy as a second step. I think that will be okay. So I think offering patients with CIS bladder preservation is reasonable. And I think BCG afterwards sounds like a reasonable plan.
I have two questions. First one is about the dose constraint.
Yeah.
About those constraints while you do the bladder boost. Second one is about the CIS. If you do CIS with definitive recurrent CIS with definitive RT, how about the dose?
Yeah. So dose constraint for bowel, I think all of us may use slightly different dose constraint for small bowel. And I don't have a firm dose constraint. It's more, I'm willing to take small bowel to about 60 gray. I don't want to go too much above that. That's my personal philosophy. So that's what I do. And that's why this one I stopped at 59.4. So 60 gray is sort of my personal comfort level for small bowel. So I think the second question you have is about CIS recurrence after bladder preservation. So I think CIS recurrence after bladder preservation can be salvaged with CIS treatment. So you would do TURBT and maybe BCG treatment is what I would potentially do. We still have 5 minutes. Other questions?
I have a question about the concurrent chemotherapy because in your data just shown the gemcitabine is very good comparing with cisplatin.
Right.
Do you consider to use the gemcitabine for all patients? And how about the dose?
Yes, I think gemcitabine is okay to offer to all patients, actually. I mean, the RTOG 0712, it's a randomized trial through the cooperative group, showed very favorable outcomes. Small trial, so I do think that offering gemcitabine to all patients is reasonable. And I think it's better tolerated than cisplatin, honestly, so I think that's reasonable. The dose for low-dose gemcitabine is 40 milligrams twice a week, something like that. I'll have to look at the 0712 JCO paper. But so the thing that we have to communicate to our medical oncology colleagues is that it's not full dose gemcitabine, which is 1,000 milligrams per meter squared. That's like full dose. For concurrent radiation, it's like 40, not 1,000. So it's very low dose gemcitabine, but it works very well for bladder preservation.
Thank you for your presentations. Because I used those with 66 grade for the primary tumor site. Because I used the field and field and IMRT the concept.
Yes.
So to long for RT alone or combined cisplatin. How do you think about the those escalate?
Higher dose for bladder preservation. So this case was a lower dose because there's small bowel nearby. If there's no small bowel nearby, I usually give 64.8 is what I usually, that's usually my default dose is 64.8. I think that's what many of the RTOG trials use, and it seems to be quite effective. I do not know that anything above 64, 60, I don't know that going to 70 helps, and I don't know any data that going to 70 helps bladder preservation. So 64.8 is what I do. I think 66 is very reasonable.
Thank you.
I have my question about my patient because he underwent the TURBT and transferred to us for the concurrent radiotherapy, and he also has inguinal lymph node meta. And how about the dose? Your suggestion about the inguinal lymph node? Thank you.
So inguinal lymph node. Is the inguinal lymph node biopsied to be shown?
About 1.5 centimeter.
Okay. I don't know that inguinal lymph node is a common site of metastasis for bladder cancer. Probably worth biopsying. I know that we usually treat the pelvis, but we usually don't necessarily try to treat the inguinal areas. So I'm not sure about inguinal being bladder cancer metastasis, and maybe biopsy would be helpful. But if the patient is no positive bladder cancer, with concurrent chemotherapy does help with nodal metastasis. So I probably would treat. Personally, I would probably treat in the mid-50s is probably what I would do.
So, I'm sorry. So you use the mini pelvic
whole pelvis?
Yeah.
For bladder cancer, I usually use mini pelvis. So I don't treat to L4, L5. I treat to like S3, so lower. So it's a small pelvis.
So you would prevent the lymph node metastasis?
So there's actually two acceptable ways to do it. The RTOG trials use mini pelvis, so like S3 pelvis and below. That's what a lot of the American RTOG trials did. The BC2001 trial, which is a UK trial, treated bladder plus margin without treating pelvis, and that's also acceptable.
So use for the mini pelvis hold is only for this case or for all patients?
I use mini pelvis for all patients because I follow what the RTOG does. But there are many people who just treat bladder plus margin following the BC2001, and that's also acceptable. There's 2 acceptable ways to do this.
Thank you.
And I think we have to stop. Is that right? Happy to chat more. There's a session. We have sessions in the afternoon, so happy to chat more. But thank you so much for your interaction. Appreciate it.
那我们中场休息5分钟，下一场是11点10分开始，谢谢。